So next, I'm going to turn it over to Dr. Steve Pierce to introduce our invited speaker today, Dr. Martina Stippler. Steve, I'll go ahead and drive the slides while you take over on Dr. Stippler's introduction.
All right, thank you, Eric. It's my pleasure to introduce Dr. Stippler. For those of you who don't know me, I'm Stephen Pierce. I'm a neurosurgeon over here at St. Vincent's, and looking forward to joining and contributing to your team next year. Martina was born and raised in Innsbruck, Austria. For those of you who haven't been to Innsbruck, it is an absolutely beautiful place, arguably one of the most beautiful cities in the entire world, nestled there in the Alps. Martina obviously did very well growing up. She graduated from medical school at the University of Innsbruck and was all set to have a very great life there, but she wanted more. She came to America, worked as a foreign fellow with Dr. Sean Grady at the University of Pennsylvania. And at that time, our residency in Pittsburgh was expanding from 2 to 3. And so Martina came and joined us, and she was my co-resident. She was a fantastic resident to work with through our time in Pittsburgh. She then went and was recruited by one of our faculty, Howard Jonas, out to New Mexico whenever he became chairman out there. And then she moved back to the East Coast, to the Harvard University, and is in charge of neurotrauma at Beth Israel. She has worked her way up to be the residency site director at Beth Israel. She is now in charge of the medical student clerkship for all of Harvard Medical School. She's now the treasurer of the Congress of Neurosurgeons. She is a past chair of the joint sections of Women in Neurosurgery. She's a member of the board for Think First, which is a nonprofit organization that many of us are members of. And whenever I think of Martina, I think one of the first things that comes to mind is obviously we have a good relationship. My wife and I started a family a few years after residency, so we started a little bit late in life, and we were having our first child was going to be a girl. And whenever we try to figure out who would we want our girl to emulate more than anybody else, it was an easy choice. We chose Martina Stippler to be her godmother. Just for any child, we'd want to have the strength, the fortitude, the work ethic, the fun personality, and all the aspects that we'd want her to be. And that's why Martina's godmother, my child, and I'm very proud to introduce her here for the Grand Round presentation at Mayo Clinic.
All right, we'll have Dr. Stippler share her screen. I'll stop sharing now.
Thank you. Yes, thank you, Steve, and for the kind introduction, and thank you all for having me for your Grand Rounds today. I will, as Steve said, I'm a director of neurotrauma. That is my clinical and administrative passion. I'd also do endoscopic skull-base surgery and spine surgery. So I really liked the case you guys started off with. I will talk about traumatic brain injury. I know there's no trauma at Mayo, so I just want everybody just put yourself in the mind that you would take care of trauma patients or, moonlighting or whatever, but I think it will be really good for the residents. So I'm gonna start sharing my screen here. Okay. So what I will, give me 1 second. Okay. So what I will talk about is triage and management of complicated mild traumatic brain injury. I will take a little bit the temperature of the room to see what your practice is and what the practice has been for the residents. I will introduce 2 things that we did at our hospital. One was the ED observation unit, and then one was a CT protocol. I also want to go a little bit on the meta level for residents. And I kind of made my career out of this. And it started with a simple, annoying thing when I was a resident and said, why are we always getting these follow-up head CTs? And as I'm walking through my presentation, I will show you the work I did. So a simple quality improvement or annoying thing or question you have, like, why are we doing this way, really can lead to a career or at least a research focus. So let me define, as we start here, let me define what do I say, what do I mean when I say about complicated mild traumatic brain injury. You have a GCS 13, 14, 15, you have an abnormal scan. That could be a skull fracture, that could be a traumatic cerebral hemorrhage, that just you need to have a traumatic finding on your CT scan, but you have no neurological focal deficit. There is no drift, there is no weakness, no blown pupil. So this is how I want you to think about all these patients that are presenting. Most of the patients where we see a decrease in GCS is either that they're elderly and demented or that they're intoxicated. Probably some of you know intoxication and traumatic brain injury goes hand in hand most of the time. So I want to make this a little bit different and interactive because it's so hard to pay attention on Zoom. So I want to kind of get you, so take your phone, take a QR code, and it should get you to a poll question. Okay, I just tried it, so it's working with me. I know there were international audience. Not sure if it works for the international audience, but I hope it does. So the first questions I have out there, it is my practice to routinely perform a follow-up head CT in patients with complicated mild TBI. And just click, and then we should see the answers come up here. Okay. Let me see. I'm not sure if it's, let me share my screen. Whatever happens on my desktop stays on my desktop. I think that's the new rule of Zoom. Steve, do you see the poll? Did it come up?
Trying to pull it up here.
Okay.
Yeah. Yes, we can see it.
Okay, great. So here we are. Most of the time, that does not cope with my practice. Thanks for being honest. So this is a good start. So I think I have the right audience here, that most of you would get a follow-up head CT. So I'm gonna go to the next question. If you go to your phone and just renew. So my notion is that a routine follow-up head CT is not deemed necessary in complicated mild traumatic brain injury. I'm going to have this a little bit of discussion. So this is my notion that we don't need follow-up head CTs, and I just want to see who is for and against. And you should be able to pull this up, and I will show the results here. Okay, so 55 of you are against, 44 are for it. And now, of course, to have a real debate here, I'm going to write the numbers down. Once I gave this talk, and it was worse after I gave the talk, which was not great. Okay, so I am now, yeah, if you refresh, because we need, the next question is, are you willing to change your mind? Because if nobody is willing to change your mind, then we don't really have a debate. So 55 said, no, we absolutely need a follow-up head CT. And then I just want to see if you're willing to change your mind. Great. I should stop collecting questions right there. But yes, you guys are willing to change your mind. Okay, so let's get right into my back to my talk again. So traumatic brain injury, before we had a real pandemic, I always like to say traumatic brain injury is the pandemic of the new world. Pandemic is not a hot word right now. There's a lot of negative connotation, but traumatic brain injury is really a silent pandemic. It affects everyone. It's world in the second and third world, but really even in the United States, every 7 minutes, somebody dies from a traumatic brain injury. And it is really an incredible number if you think about it that way. If you think about the financial burden of the productive life lost, it's about a mission to Mars and back. So we see we see it in our population, and it can affect everyone. I want to show you this trend. So if you look at this trend here, you can see that there was an increase, a tremendous increase in admissions, ED visits, and hospitalizations. This is the top two numbers, and about started 14 years ago. It's a tremendous increase of use of healthcare resources. And it really, if you look at it, is a subgroup of patients that actually have mild traumatic brain injury. And anybody that works in a level 1 trauma center, and probably your residents know that, there are a lot of these patients, neurosurgery get called, and we have about 10 calls a day in our institution. And what I want to postulate is this phenomenon that we see more and more of these patients, and they get admitted, and that they come to ED has multiple reasons. One, there is an elderly population, and we will see in the next slide, elderly patients are much more likely to fall and have a traumatic brain injury. Number two, our CT scanners have gotten much better. So we see things that we didn't see 20, 30 years ago. And there also has been an increased awareness of traumatic brain injury. And that leads to an over-triage, an over-treatment of patients that is clinically and medical not necessary. So let me repeat that. That leads to an over-triage that is really clinically and medically not necessary. So if you look at these numbers, again, you see there was about a 24 increase of traumatic brain injury visits to the ED because of motor vehicle accidents, but there was an 80% increase of TBI-related ED visits from falls. And we all know who falls. It's the elderly patient. It's the very young, which we don't see if we don't work in a children's hospital, but it's the elderly patients that keep falling. And what are elderly patients on? I know it from my trauma TBI database. 50% of my patients, if I include aspirin, are on some form of antithrombotic or anticoagulation. So you really have that silver tsunami of an aging population. Everybody's on some anticoagulations, they fall and they end up in your ED. So you really need to have a good, protocol what to do with these patients. You need to evaluate, should they be admitted? Do they go to the ICU? Do they need a follow-up scan? Do they need a neurosurgery consult in the first place? So that's what I want to challenge with my talk today. Okay, take out your phones again. We're going to a case. And the first question here, so this is a 55-year-old male, GCS 15, he fell off his Peloton bike, and he's neurologically intact, and he has this little series 2/13 traumatic submarinal hemorrhage here on the left scan. And my question to you is, it should be activated, refresh your screen if you don't see it, but would you get a follow-up CT scan in this patient? Away from my and show you the results here. Okay, so 64% of you would get a follow-up CT scan in this patient, goes up a little bit, and a third wouldn't. And I think that's what we try to address. I think when I started our protocol, we got follow-up CT scans at everyone. It's just our protocol. Put them on Capra, get a follow-up CT scan. And I remember when I was a junior resident with Dr. Pierce, we waited 24 hours for the follow-up scan. Then I became a junior resident. We waited 12 hours for the follow-up scan. And then my residents and my APP now wanted to always narrow that window. And I'm like, well, why are we getting it at all? And I will share the data that we accumulated on that topic. And the next question, I will highlight that. So how would you treat this patient? What would you do? Would you admit this patient? Would you observe him in the ED? Would you discharge him to home? How would you treat this patient? So 60% of the people would admit him. It's actually growing. Okay, 75%, 80%. Well, I hope I'm gonna make a dent here in your practice of traumatic brain injury. Is that we ops this patient in the ED. Neurosurgery sees the patient once. We don't get a follow-up PET CT, and we are sending him home. from the emergency room after 6-hour observation period. So let me show you a little bit how we got to this protocol. So 2/3 of all traumatic brain injury in the United States are classified as minor. Less than 10% of those actually have a positive head CT. So that's the one we get called about. And less than 1% of those actually need a neurosurgical intervention. That probably would be your epidural hematoma that you see during a lucid interval. So when we started this, we really wanted to see, we had all these patients come, I think 10 a day, where do they fall in? How can we do that? Can we admit them? ICU, we just heard this video that we're gonna run out of beds. So this is, we wanna really be conscientious where we admit these patients to and how we allocate our beds. So this is, I worked with the emergency room group and the trauma folks, and this is kind of this algorithm we came up with. If you have an isolated head injury, if you're GCS 14 or 15, and it was related to intoxication, and if you had a traumatic subdural hemorrhage, a subdural less than 1 centimeter, and a small contusion without midline shift or mass effect, you ended up in ED ops. ED ops, it's part in the emergency room. We took Q4 our neurochecks, and the patient stays there for 6 hours. Look at the things that exclude that patient. So we're excluding the patient if they have a lower GCS. Epidural hematomas, we're automatically excluding them. Any skull fractures, we're excluding them. If there's skull fracture with intracranial hemorrhage, could there be a missed epidural hematoma that is developing? Post-traumatic seizures, because it indicates a more severe traumatic brain injury and also can make the exam a little bit difficult. We gave the e-attending, if they didn't feel comfortable, they could just say, admit the patient. I just don't like the gestalt of this. And then we got into anticoagulation, right? Initially, if we really would include aspirin as well, then we couldn't apply the ED ops to about 50% of our patients, because many patients are on anticoagulation or antithrombotics. That's what we did. We published our results, and overall, in about a year, we could enroll about 138 patients out of 200. And what was really interesting for us, and I don't know how your referral pattern is in Mayo and in trauma hospital you work, but we realized that a lot of these traumas actually were coming from our rural hospital and referral hospitals. So 80% that were transferred to us, we sent home. And that actually led to another project, and the pandemic was a real good catalyst for that we are now having telemedicine, and it's consultation. It's a telehealth enhanced consultation with with the emergency room. So we're not talking to the patients. It's a physician-to-physician consultation, but we do this now in all our peripheral hospitals, and the patients don't get transferred here. It's a little bit a bigger learning curve because they need to be comfortable taking care of these patients, and the nurses need to feel comfortable doing that. But that was, again, a big way for us to decompress our hospital and really use the beds. So if you look at this study in detail, you could see that 81 patients were discharged to home. They spent about 17 hours in the emergency room, and none of the patients that we actually admitted needed neurosurgical intervention. It's a given that the patient that went home didn't need a neurosurgical intervention. But I want to really point out, and I get a lot of pushback now sometimes from the peripheral hospitals, where we ask them keep this patient, that even the patient we deemed more at risk for deterioration or worsening, even these patients, none of them, even the patients in our exclusion group, did not need a neurosurgical intervention. And I think that is important. We looked at the patients that bounced back, and one was an acute subdural hematoma that became a chronic subdural hematoma, and some were headaches, but none of them had any injury or anything that we missed or had a poor outcome from that. So now I want to shift from what we're doing with the patient, where we put them in the hospital, and I want to shift a little bit. Where do we need this follow-up PET CT, right? Do we need the follow-up PET CT? And I'm going to activate the next poll again. And what are some of the reasons? What are some of the reasons that we are getting this routine follow-up PET CTs? And you should be able to type in some of these reasons for me. Just refresh your screen. Legal risks, so persistent symptoms, exam change, to monitor for expansion of intracranial hemorrhage. So as they're coming in, so yes, so the legal environment, always lacks, let me see if I can make this better. So the legal environment always lacks the environment that we are practicing, about 10 years behind. And I would say the way we made it kind of a protocol through our institution and through our network. So it is kind of our regional standard of care. That really is protecting us of what we're doing. Exam change, absolutely. You will see that in the things I will present going forward. To monitor intracranial expansion, I will tell you, newsflash right now, 20% of your intracranial hemorrhages will expand. Okay, they will expand. We have the data, 20% expand, but that has no, if it's not correlated with an exam change, it's completely meaningless. We looked, to have a good example for that. So we looked at patients, complicated mild traumatic patients, then came in on NOACs, and we didn't want to give them $100,000 of andexanet to reverse Eliquis. So we said, how did these patients do? And there was this one patient, he had a traumatic summer hemorrhage, and I looked, and I said, oh my God, and in our data sheet, it said it increased 400%. I'm like, oh my God, did this patient die? What happened? Well, it was a 2 millimeter subprime hemorrhage that just spread out and became a 4 millimeter subprime hemorrhage. So I think just the pure term of expansion, I think we need to be careful about. We know they're doing, but are they really clinical meaningful? Is that even where you're going to make a different clinical decision based on this patient? And I probably am going to challenge you and say that you probably, all of you, have looked at the radiology reads where it says worsening this, worsening that, and you, send the patient home. So I think it's just, you need to have the clinical correlation with that. Persistent or new symptoms, I would say if the symptoms persist, I think that's what we see sometimes with the from a traumatic brain injury, but new symptoms, definitely check for bleeding extension at uncomplicated fracture. Yeah, so I think that those were good points. I think I totally agree. Exam change, you want to do that, but I think what I want to get at with this question is that it's actually sometimes we get a false sense of security because we scanned the patient. And the patient, just because you got a CT scan 4 hours later and it didn't change, doesn't mean the patient could deteriorate 2 hours later. So I think what I want to argue for is the CT scan, if it's not related with a clinical deterioration, doesn't really help us to make a decision point, but the neurological exam and the follow-up is very important. So why do I argue for that we overtreat and provide this medical treatment that's not really necessary? Here is the beginning of a CT scan. So a CT scan was invented in 1972 by Hounsfield and Cormack at Tufts University here in Boston, Massachusetts. He was later awarded the Nobel Prize in Medicine and Science for his invention. The first CT scanners were installed in the 1974 to 76. And now we have about 6,000 CT scanners in the US and about 30,000 around the world. The first CT scanner took 6 hours just to calculate one slice. And you can kind of see here the quality of the images. And I really want to challenge you to see a traumatic submural hemorrhage on that image. And here you see the scans side to side. So this is an original CT scan from 1975. And this is now the CT scan, a state-of-art CT scan we are having. So way different quality. And as our imaging technologies has improved and our sensitivity to pick up 2 red cells in the traumatic submural hemorrhage space, I think our treatment algorithm and our treatment paradigms have not changed. And I think it's about time to do so. This is actually not that long ago. So this is from, well, it's depending on your perspective, but this is a CT scan, and you really can see the evolution of the CT scan. This is a patient who was followed for a brain tumor from the 1978 to the 91. And you can see, you know, the evolution of the quality of the CT scan, and just putting this in the contrast what we're getting now. So our imaging is getting better. We're seeing things that we probably wouldn't have seen in 30 years ago, but we still have the same treatment paradigm. So all the way back, and that's what I wanted to encourage the residents, going a little bit on a meta level. So this is something I have struggled with, and this was my first year as an attending. I worked in New Mexico. We were the only level 1 trauma hospital, and people literally had to drive 5 to 8 hours to come here. If people were transferred for this mild traumatic brain injuries, it was a fixed wing transport because the distances. And then we saw these patients, and it took them like 12 hours to get here, sometimes even longer. And we just admitted them because we just felt bad to send them back home. And sometimes they came out of the 24-hour window. We repeated the CT scan because we had to do something. They came all the way, and then we said, yeah, well, you can go home. And there was a lot of lost resources, a lot of lost money in the healthcare system of transporting these patients this far distances for us more or less not to do anything. I think we felt that we allocated our hospital beds not to the right patients. And there was also hardship for the patient itself, because most of them said, well, my family cannot pick me up. We don't have gas money to drive that far. And that spared the systematic review, where we just looked at everything that is published. We did a meta-analysis. We found that the average follow-up CT scan was done in 21 hours, that the first CT scan was mostly done within 2.5 hours from injury. And that we see interprogression, that's where the 20% came from. We see injury progression about 19% of the patients. But what we also found is that change in routine follow-up PET-CT did not predict neurological decline or need for neurosurgical intervention. So let me repeat that again, because that is very important. I think that is how we practice currently. Change in routine follow-up PET-CT did not predict neurosurgical decline or intervention. So just if you have that traumatic submural hemorrhage go from 2 to 4 millimeter, it really didn't predict that the patient needs surgery. It didn't lead to any treatment changes, and it didn't relate or correlate with neurological decline. There are other reasons why you can have a neurological decline. Could be seizures, could be that you were agitated in AD and got medication. It's maybe the seizure medication that makes you sleepy. So there are other reasons, and I think it's still correct to image that patient, but it doesn't have anything to do with neurological deterioration. The second part is what we found: a symptomatic PET-CT absolutely predicted that you needed to do something for this patient. And that's what we are proposing now. We then did the study prospectively, where we kind of collected this data on these patients for a couple of years and saw what we found. And it was very interesting. Of course, this is, we didn't change our practice, and you could see there were epidural hematomas that needed a delayed operation. All the patients we included here, and I maybe should have said that. So these are patients that we looked at the first PET-CT and said, you don't need surgery. Okay, so this is not the patient where we said, yeah, you have a centimeters of dural hematoma, you're going to the OR, or yes, this is an epidural, you're going to the OR. So this is a patient where, based on the first PET-CT, we didn't think you needed surgery. So none of there were no epidural hematomas that had a delayed surgery, and that was our own bias because we operated on them, right? So keep that in mind when you look at this data. But we saw definitely some subdural hematomas that progressed and needed surgery. So let me pivot a little bit. So I'm not the first one that is saying you don't need to do follow-up PET-CTs. There is Dr. Joseph in Arizona. He is a trauma surgeon, and he developed the brain injury guidelines, a big protocol where he said, listen, all of these patients don't need follow-up PET-CTs. They also don't need a neurosurgical consultation. And he came up with these guidelines as you see on the screen. So let me just walk through a couple of them. So loss of consciousness, well, yes and no in all categories. Category 1 or 2, you had a normal exam, intoxication or no intoxication, none of any anticoagulation, which was later changed. And then he came up with subdural hematoma 4 millimeter versus 5 millimeter, epidural hematoma 4, 5, 7 millimeters. So you can see these are not really numbers we neurosurgeons use. I think we are using the volume or centimeter epidural hematoma, the same with the subdural hematoma. I don't think we would treat people different if they have a 4 versus a 5 millimeter subdural hematoma, but when it reaches a centimeter, that's where our treatment and paradigm kind of changes. But he instituted that, and he said, if you're in one of these categories, if you're in big 1, you don't get a head CT, you don't get a neurosurgical consult. Even in big 2, you're admitted, but you don't get a head CT, you don't get a neurosurgical consult. If you're in big 3, you get all 3. And I'm not advocating that they should see neurosurgery, but what I'm on the show that I'm not the only one thinking in that direction. And also, I'm speaking out of a place of privilege because we have a very good coverage of neurosurgery in Boston. You cannot hit a stone to see to hit a neurosurgeon, and our population is not underserved. There are many areas in the United States that is very underserved for neurosurgeons. Neurosurgeons don't want to take call. They give up their brain privileges, so their malpractice insurance goes down, so they cannot take neurotrauma call. They just focus on the spine practice. It's very disruptive for private practice neurosurgeon to take that call for their elective practice. So there are many areas in the United States where there is a big shortage of neurosurgeons, and the neurosurgeons that are there don't want to take trauma call. So this is why people looking for solutions and really want to use the neurosurgeons more for things that matter and not where they think that they are not needed. So I think that's where these kind of protocols have arisen. It is also, I think, I presented this work at meetings, and private practice neurosurgeons came up to me and said, hold on, you get a follow-up head CT? We never do this. And why don't they do it? Because they don't have residents to go down there, order the follow-up head CT, look at it, and write the sign-off note. So again, I think we have a different view in academic medicine, because it's convenient for us and because we have, our residents who have the brunt of this work, that we maybe have to rethink of changing our practice, because it might be easy and no cost to us and no sweat off our back. But I think it's maybe not necessary. And we want to provide good care, but also cost-conscious care, and not expose patients to radiation they don't need, and not use ICU beds they don't need. There's another thought while it's important, because if we work academic centers, if we train residents, we also train the trauma surgeons. You as neurosurgeon also teach the trauma surgeon how to take care of traumatic brain injuries. You as neurosurgeon also teach the emergency room how to take care of these patients. So if we want to move our field forward, if we want to change the paradigm and change the treatment algorithm, we actually need to teach other specialties how to use this paradigm in a safe environment during their residency. Do they feel out comfortable and practice that and bring that forward? This is a slide of how much they could, with this new protocol, decrease, and I just pay attention to the orange bar here. So in complicated mild traumatic brain injury, they could cut it kind of in half. You might say, well, this is great to have this protocol if you're in a level 1 trauma center where there's a neurosurgeon readily available. People implemented a protocol like this also in level 3 trauma centers, in rural hospitals with not neurosurgery readily available. They also included aspirin, because if you don't include aspirin in your group with not a follow-up PET-CT, you cannot just enroll many patients. So this is the protocol that we developed in our hospital, and I will walk you through that. So does the patient have a GCS of 13 or 15? Yes. Is he on anticoagulation or antiplatelets? No. Does he have a HET-CT that shows an epidural hematoma or a subdural hematoma greater than centimeter? No. Then the patient does not get a follow-up PET-CT. So if you don't have an epidural and if your subdural is not a centimeter, whatever your complicated mild traumatic HET-CT scan shows, you don't get a follow-up PET-CT. And we have implemented that and studied that. And I think it's time to wake you guys up again. Sorry, I didn't want to do that. And do another poll here and see if you feel comfortable practicing this way. Let me activate the next poll here. How comfortable would you feel practicing this way? So if you have a contusion, if you have a traumatic subarachnoid hemorrhage, you don't get a follow-up CT scan as long as you fall on the parameters. And then if you have a subdural, that's of course a centimeter, you would get this. Okay, so let's compare the numbers. Okay, so initially I had like 45% said they would get one, 45% said they wouldn't get one, 55% they would get one. And so 63% would agree that you could do that. 25 are neither here nor there, and then it's dangerous, I will never do that. I mean, I don't know if these people want to speak out. You can put it in the chat. If you want to disclose yourself, maybe I can address your concerns. But I think we have really robust data. Well, we have good data. We will move this to the next phase. We will move this to the next phase and make this a multi-center study, because our N, as you will see here, is not in the thousands. And I think the event rate is low. So we need to get that in the thousands. But this is what we did over a year. So and I will end on time, so no panic. So this is what we did in a year. So we had 175 patients. Mean age was 68. You see they're elderly. The mechanism is false. All falls in the cohort that I described. These are elderly patients that are falling, that fall into this category. The mean GCN was 15, and then 45% of them had some anticoagulation on board. And this is how we triaged them through, right? So we, based on what we saw, they either got a triage to routine follow-up PET-CT, and the reason was following. They had a epidural hematoma, the contusion size, there was a subdural hematoma size, and they were on anticoagulation. So these patients, we triaged that you need a follow-up PET-CT. Then there were patients where we said, no, according to this protocol, you do not need a follow-up PET-CT. And there were some violations, right? So this was a really paradigm change for our emergency room, even for some of my attendings. So there was definitely a learning curve. I would say acute care surgery had the least amount of pushback. The ED fell in line quite well. And I think it took, I think some of my co-faculty, a little time not to do the follow-up PET-CT. And then, I think that came up with one of the questions I put out there is, so there were some neurological changes, and this were about 8 patients, and then we got a CT scan. Okay. Overall, in our cohort, we could avoid 71% of our head CTs could be avoided with this protocol. We looked at our follow-up. We saw patients come back to the ED. We looked at our 30-day follow-up, and there was one patient that came back and needed a surgery. And I think just to make my point, the patient had a subdural hematoma that became chronic, that increased in size, and that needed surgery. And the patient was actually in the follow-up head CT group. So he got triaged to get a follow-up head CT, but that did not prevent him from coming back 2 weeks later and needing surgery for the chronic subdural hematoma, because that's not what we're screening for. We're screening for acute deterioration and acute worsening. But 71%, we didn't admit them to ICU beds. We keep them in ED ops, and 71% of our head CT could be avoided, and not have to do cost savings, but also with the flow in the ED, and getting the patients to the system and providing patient-centered care as well. But it's also important to know that we're now rolling this out to the other hospitals. And, depending on how much your CTs can cost or not, that can really amount to some money. So I'm going to stop right here. That is our paradigm. I walked you through it. I walked you through my academic work, how we got there, and would love to open it for questions or criticism, or also invite collaboration. I know the residents that it would be a good quality improvement project if you maybe want to start this off in your trauma hospital where you rotate. Because the good thing is there are a lot of patients that fall in that category, and you can get a good number right from the get-go. So I will stop sharing my screen there and see if there's any questions or comments.
Hey, thanks a lot, Martina. That was excellent talk. I had one quick question. What, a non-depressed skull fracture without blood, is that something you would repeat a CT on or not?
So it's just a skull fracture without blood?
Yeah.
So we, if there is no blood, we ED ops them. So we wouldn't repeat this. Also depends on, when has your first head CT done, right? If this is somebody, I think the late epidural hematomas you see most often if you have your first head CT in less than an hour, right? So you want to pay attention to that. Like if the patient came from the scene and got the CT scan within the first hour, that maybe change hours, but we would right now ED ops them. Yeah, I see David, Dr. Miller has his hand raised. I think you're muted.
Most of my colleagues prefer me that way. No, I'm an interventional neuroradiologist. I found your talk fascinating. It's a great topic, and you've obviously done a lot of really impressive work. I think some of the rise in the patients have admitted it comes with a greater recognition of problems in this area. So my question sort of is, I think that obviously, MRI techniques have become much more sophisticated, SWI and other things, and offer for the radiologists offer a much I think a wider and more impressive view, or a more helpful view of mild changes in the brain. Obviously, from an economic standpoint, the system can't be doing MRI scans on all of these people. But do you see a time of a future where we will further stratify these patients and recommend perhaps some of these sophisticated MRI follow-ups in some of these patients with otherwise negative results?
Yeah, so I think that this is a very interesting point you're bringing up. And if you look at we neurosurgeon, if we say you have mild traumatic brain injury, it's actually not mild. And you need to go out of our silo, talk to rehab folks, talk to neuropsychologists, to people that work in concussion clinics to actually see that. And there was a wonderful study who used exactly that. They did in patients that we say, you're mild, go home, from a neurosurgical mild. And they did functional MRIs and gave them tasks to do. And it was amazed how even a year out, somebody with a mild traumatic brain injury had to recruit much more brain as the task got more difficult, to do the same task. So yes, when I say mild, I'm saying you're not going to die right now. That's the neurosurgical definition of mild. If you got a neuropsychology, talk to TBI, concussion specialists, there is a lot we don't look and we don't treat as neurosurgeon, but I see that trend definitely happening. But I think outside of the ER, this is for your neurocognitive rehab. How do we treat concussions? How would you treat this mild traumatic brain injuries? Because you're absolutely right. We neurosurgeons have a different definition of mild than some other specialties do.
Perfect. Thank you very much. And thanks for the talk. It was really very, very enlightening.
Are there any other questions or comments for Dr. Stippler?
Martina, hi, it's Chris Fox. That was a fantastic talk. Thank you so much. I'm just curious, how much pushback did you have from other services when you initially tried to institute these guidelines?
So you need to increase the temperature slowly. You cannot throw them in it. So we did it multidisciplinary. So from the get-go, I had ED and I had critical care and trauma with me. And you can see the initial protocol was, if you guys don't like it, we can admit him. Right. So we gave them kind of the out, and it was, and I think we had really sponsors in in trauma surgery and ED, and that really helped us. We did a QA process on all the patients, and then in the first year, we actually saw them back, right? So we saw them back, said, no, you guys need to come back. And even if you don't get a follow-up CT scan, you need to see them 6 to 12 hours later. And then the pandemic hit, which was a beautiful catalyst. And we said, we have been coming back for 2 years and we never do anything. And now that your ED is full of COVID, can I not send my APPs in there? Are you guys okay? And then they said yes. Because, and I think having our data and having this data and having it published really brings them on board. I say now in our peripheral hospitals, right, where there's no neurosurgeon, neurology and medicine gives us pushback. They are definitely harder to get on board, but emergency medicine, I think, is easier. But the more data we have, it's better. And I think the next layer would be really do this multi-center so we can get in the thousands to really see that it's safe.
Yeah, I mean, I think it's fantastic. We need more of this evidence-based type of approach, particularly as our resources in neurosurgery they get stretched thinner and thinner each year. And it's really important, as you mentioned, for us to be focusing on things we can do to help rather than just doing it the way it's always been done, which seems to be pushed by many people who are not neurosurgeons.
Yeah, I think well said. And I think the multidisciplinary approach, and if you include them in the papers and in the presentation, I think if you have a champion, they can help you move it forward in their specialty.
Yeah. Well, thanks so much for your talk. This is excellent. Congratulations on such great work.
Thank you, Chris.
All right, there's no more questions for Dr. Stippler, then we'll conclude. Martina, thanks so much. That was an excellent lecture, and I think we're meeting again here in about an hour or so.
Okay.
All right.
Thanks, everyone.
Thank you all.
Thanks for the opportunity and invitation. Bye-bye.